Welcome to the deep dive. Forget wading through endless textbooks. Think of this more as your power-packed session to really nail a key medical topic.
Yeah, exactly.
We've gone through the notes, and today it's all about efficiency, getting you the crucial knowledge you need, right now.
Precisely. We're taking a really focused look at deep venous thrombosis, DVT.
DVT.
Our goal is pretty simple. Pull out the must-know information, what it is, why it happens, how we manage it, all in a way that actually sticks.
Exactly. So we're going deep on the definition, the why, the etiology, who's at risk, what's actually happening in the body, the pathophysiology.
What else it could be? The differentials.
Yeah, who gets it, how it looks clinically, how we find it, manage it, what to expect prognosis-wise, and of course, potential problems.
Yeah, we'll try to weave in some memory aids, maybe some examples too, just to help it all click.
Okay, ready to dive in?
Absolutely. Let's kick off with the basics. What actually is DVT?
Good place to start.
Well, at its core, it's a blood clot, and it forms in one of the deep veins in the body. Usually, like you probably know, it's in the legs.
Okay, deep vein, leg clot, got it. But it's not just a local issue, is it? I remember something about VTE and the big worry, PE.
You're absolutely right to bring that up. DVT is a major part of what we call venous thromboembolism, or VTE.
VTE, okay.
And the huge concern with the DVT is that bit of clot can break off, travel up through the bloodstream,
Right.
and end up lodging in the lungs. That's a pulmonary embolism, PE, and, well, it's serious, potentially life-threatening.
Okay, so DVT leading to PE is the big danger. That really hammers home why spotting it and treating it quickly is so vital.
It really does. So let's think about what actually causes a DVT to form in the first place. The classic model for this is Virchow's Triad.
Ah, yes, Virchow's Triad. That sounds important. Key concept.
Definitely one to remember. Think of it as three main factors that can upset the normal balance and, well, lead to a clot.
Okay, what are the three parts?
So the first one is hypercoagulability. Basically, the blood has an increased tendency to clot. It's stickier, if you like.
Right, clots too easily.
The second is hemodynamic changes. This just means changes in blood flow, so blood pooling, moving slowly, that's stasis, or even turbulent, disrupted flow in the veins.
Sluggish flow or disturbed flow.
Got it.
And the third?
The third part is endothelial injury. That's damage to the inner lining of the blood vessel itself.
Damage to the vein wall.
Exactly. Any one of these, or often, a combination of them, creates the perfect storm for a DVT.
Okay, increased clotting tendency, blood flow issues, vein wall damage. I can see how those fit together.
Yeah.
So who are the people most likely to experience these things? What are the main risk factors for DVT?
Well, there's quite a list, actually. It helps to group them a bit.
Okay.
Think about things like prolonged immobility, long flights, being stuck in bed after surgery or illness.
Right, makes sense.
Obesity is another big one. Pregnancy definitely increases the risk. The UK incidence is around 1 in 1,000 live births.
1 in 1,000, wow.
Yeah. And just getting older, advanced age is also a risk factor in itself.
Long journeys, obesity, pregnancy, older age. Those seem quite intuitive. What else should be on our radar?
Hormonal factors.
Yeah.
Like hormone replacement therapy, HRT. Then there are genetic things, we call that thrombophilia, inherited conditions where your blood is just more prone to clotting.
Thrombophilia, right. Inherited risk.
And then there are specific medical situations. Surgery, obviously, major trauma. Cancer is a significant risk factor, having had a VTE before.
A previous clot, yeah.
Exactly. Thrombophilia comes up again here as a condition. Heart failure, varicose veins, direct injury to a vein, and also antiphospholipid syndrome. That's an autoimmune thing.
That's a pretty broad range of medical risks. Anything from sort of lifestyle or general health?
Yes, definitely. Smoking is a known risk factor. Interestingly, being male slightly increases risk too.
Right.
And even dehydration can play a part, making the blood a bit thicker.
Right.
And it's worth remembering, in a lot of DVT cases, maybe 50 to 70%, we can actually pinpoint one or more of these risk factors.
So a whole host of things can contribute. Now let's get down to the nitty-gritty. What's actually going on inside the vein when a DVT develops? The pathophysiology.
Okay, so fundamentally, DVT pathophysiology is about an imbalance. Normally, your body is constantly forming tiny clots and breaking them down. It's an equilibrium.
Right, a balancing act.
Exactly. But in DVT, that balance gets disrupted. Either you get too much clot formation or your body's ability to break down clots fibrinolysis is reduced. Or often, it's a bit of both.
Okay.
And this leads to this thrombus, this blood clot, building up inside the deep vein. It obstructs the vein, blocks it, and stops blood flowing properly back towards the heart.
Like a blockage in the pipes, essentially. Okay, so if someone comes in with symptoms that could be a DVT, leg pain, swelling, what else might be causing it? What are the main differential diagnoses we need to think about?
This is really crucial because the symptoms aren't always specific to DVT.
Right.
You could have musculoskeletal issues, like a simple muscle strain or tear, or cellulitis, that's a skin infection, which can cause redness, warmth, swelling, pain. It's very similar sometimes.
Cellulitis, yeah, that's a common mimic.
Definitely. Superficial thrombophlebitis, a clot in a vein closer to the surface, can also look similar. And the tricky thing there is sometimes it can actually hide an underlying DVT deeper down. So you need to be aware of that.
Okay, so muscle problems, skin infections, superficial clots, need to rule those out. Any other key differentials?
Well, you need to consider compartment syndrome, that's increased pressure within a muscle compartment, a surgical emergency usually.
Yeah.
Arterial ischemia too, lack of blood supply to the leg, which is different but can cause pain.
Right, arterial versus venous, important distinction.
Absolutely. Then there's a broader list, things like recent trauma, post-thrombotic syndrome, which is a complication of a previous DVT.
We'll come back to that one, I imagine.
We will. Also, general peripheral edema from things like heart failure, liver cirrhosis, or nephrotic syndrome, maybe an obstruction higher up, venous or lymphatic. Less common, things like an arteriovenous fistula, congenital vascular issues, vasculitis, maybe a ruptured Baker's cyst behind the knee, even septic arthritis.
Wow, okay. That's a pretty hefty list. Really shows why you need a proper workup, doesn't it? So, moving on, how common is DVT? What's the epidemiology look like, say, in the UK?
In the UK, we see about 1 to 2 cases per 1,000 people each year. That's the general population incidence.
1 to 2 per 1,000.
Yeah. But it's much higher in certain groups. We mentioned pregnancy, about 1 in 1,000 live births. And in people who are critically ill, in ICU, for example, the rate can shoot up dramatically, maybe even as high as 37% in some studies.
Goodness, 37%, that's huge. So what are the main risk factors that pop up again and again when you look at the population level?
Well, epidemiologically, the big ones that consistently stand out are having had a DVT or PE before, being over 60, recent surgery, obesity, prolonged travel, having an acute medical illness needing hospitalization, cancer, immobility, known thrombophilia, and pregnancy, those really dominate.
Okay, the usual suspects mostly.
Pretty much. But there's another important point here about epidemiology, underdiagnosis.
Ah.
Yeah, it's a real issue. A lot of DVTs and even fatal PEs actually go undetected. It's estimated that PE is only even suspected before death in less than half the people who die from it.
That's quite sobering.
It is. And even though sensitive tests often find a DVT in patients who do have a PE, often those patients didn't have any obvious clinical signs of the DVT in their leg beforehand.
Which brings us neatly to clinical features. How does DVT typically present when it does present? What should we be looking out for?
The classic symptoms, when they occur, are usually in the calf or thigh. Things like pain, swelling in the affected leg, a feeling of warmth, maybe some redness and tenderness if you press along the line of the vein.
Pain, swelling, warmth, redness, tenderness. Okay.
And this is a really key point, a huge proportion of lower limb DVTs, maybe up to 65%, cause no symptoms at all. They're asymptomatic.
65%. That's astonishing.
Okay.
So given that, when should we really have a high index of suspicion?
You absolutely have to consider DVT in any patient who presents with new onset leg swelling, pain, and warmth, especially if there isn't another obvious cause.
Right.
And this is where using a clinical prediction tool like the Wells score comes in really handy. It helps you estimate the pretest probability before you jump to imaging. And always keep those differentials, muscle tear, cellulitis, Baker's cyst, etc., in the back of your mind.
Okay, use the Wells score. And what about specific signs on examination? What might we actually find?
On examination, yeah, you might feel tenderness, particularly along the deep veins. Unilateral swelling is a big clue. One leg noticeably bigger than the other, often measured at the calf or thigh.
Unilateral swelling, okay.
You might see pitting edema. You press the swollen bit, and the indent stays for a moment. The superficial veins might look more prominent, distended. The skin might feel warmer on that side.
Warmer, yeah.
And the color might change. Could be red, erythema, or even purplish or bluish, cyanosed if it's severe. Sometimes, though less common, you can actually feel a firm cord, which is the clotted vein.
A palpable cord.
Exactly. And just to reiterate, cellulitis can look very much like DVT and vice versa. And you might see superficial thrombophlebitis alongside a deeper DVT.
Got it. So a mix of symptoms and signs should trigger suspicion. How do we then confirm it? What are the key investigations?
The absolute mainstay, the primary diagnostic tool, is Doppler ultrasound imaging.
Ultrasound.
Yes, specifically compression ultrasound with Doppler. It's non-invasive, readily available in most places, and it's very good at visualizing the clot and the blood flow, or lack of it, in the deep veins. It's the first-line choice.
Okay, Doppler ultrasound first. What about blood tests? I hear about D-dimer a lot. Where does that fit?
D-dimer. Yes, it's a laboratory test. D-dimer is a breakdown product of fibrin, which is involved in clots.
Right.
Its main value is in ruling out DVT. If someone has a low clinical probability of DVT based on their Wells score and their D-dimer test is negative, then it's very unlikely they have a DVT, and you often don't need to proceed to ultrasound.
So good for ruling out in low-risk patients.
Exactly. But the problem is a positive D-dimer is very nonspecific. Lots of things can raise it: infection, inflammation, pregnancy, cancer, recent surgery, even just being older. So a positive D-dimer doesn't confirm a DVT, it just means you do need that ultrasound.
Okay, that clarifies its role. So risk assessment first, like with Wells.
Definitely. That guides whether you do D-dimer or go straight to ultrasound.
And then depending on the picture, maybe further tests like looking for cancer or thrombophilia.
Potentially, yes. Especially if the DVT was unprovoked, meaning there wasn't an obvious recent trigger like surgery or immobility. Then you might consider screening for an underlying cause.
Right, makes sense. So let's say we've confirmed the DVT with the ultrasound. What's the plan then? How do we manage it?
Okay, management. The main goals here are stop the clot getting bigger, prevent it from breaking off and causing a PE, and reduce the risk of it happening again.
Prevent extension, prevent PE, prevent recurrence. Got it.
And the absolute cornerstone of treatment is anticoagulation therapy, blood thinners.
Anticoagulation. Okay. What are the options? How do we choose?
Well, first off, before you start any anticoagulant, you need to think about the patient's bleeding risk. We often use scores like HAS-BLD to help assess that.
Assess bleeding risk first. Good point.
Then, for the initial phase of treatment, usually the first 5 to 10 days, the standard approach often involves starting with an injectable anticoagulant. That's usually low molecular weight heparin, LMWH, given just under the skin.
Right.
Or sometimes fondaparinux.
LMWH or fondaparinux injected.
Yes. LMWH is generally preferred for pregnant patients and those with active cancer. If someone has severe kidney problems or a very high bleeding risk, we might use unfractionated heparin instead, which can be given intravenously and monitored more closely.
Okay. And what about tablets like warfarin?
Good question. Often we start a vitamin K antagonist, like warfarin, at the same time as the injectable heparin. The heparin provides immediate cover, while the warfarin takes a few days to reach its target level. We aim for an INR, that measure of blood thinning, between 2 and 3 for warfarin.
Right, bridging with heparin until the warfarin is therapeutic.
Exactly. Then for the longer-term treatment, say from day 10 onwards, usually for at least 3 months, sometimes longer.
How long depends on the cause, right? Provoked versus unprovoked.
Precisely. If it was provoked by something temporary like surgery, 3 months might be enough. If it was unprovoked, or if there's an ongoing risk like cancer, treatment might be longer, even indefinitely.
Okay. And the options for long-term?
For long-term, you might continue LMWH injections. But more commonly now, we switch to oral agents. These include the direct oral anticoagulants, or DOACs, things like apixaban, rivaroxaban, edoxaban, which are factor SANID inhibitors, or dabigatran, a direct thrombin inhibitor.
The DOACs, they seem much more common now.
They are. Often preferred because they don't require routine INR monitoring like warfarin does, and they have fewer food and drug interactions. Though choice depends on individual factors, kidney function, other meds, patient preference.
Okay, so a range of anticoagulant options. What about non-drug approaches? Any non-prescribing management?
Yes, definitely important. For instance, if a woman is on the combined contraceptive pill and is having major surgery, guidelines often suggest stopping it about 4 weeks beforehand to lower VTE risk.
Right, stopping the pill pre-op?
Early mobilization after surgery is key, getting people up and walking. Compression stockings might be used for prevention in surgical patients, but interestingly, not generally recommended for treatment of an acute DVT itself anymore.
Oh, that's changed then. Used to be standard.
Yes. Guidelines have moved away from routine compression stockings for acute DVT treatment based on recent evidence, though they are still important for preventing post-thrombotic syndrome later on.
Okay, noted. What else?
Well, for high-risk patients in hospital, we give prophylactic LMWH to prevent DVT. And if someone absolutely cannot have anticoagulation, say they have active major bleeding.
What do you do then?
That's when you might consider an inferior vena cava filter, an IVC filter. It's a little device placed in the big vein in the abdomen to catch any clots traveling up from the legs before they reach the lungs. Or sometimes just close monitoring with serial ultrasounds.
IVC filter as a safety net if anticoagulation is out.
Okay. Now, I know NICE guidelines get updated. Any key points from the latest updates we should highlight?
Yeah, some important ones. They stress starting interim anticoagulation immediately if you suspect DVT or PE, and there's going to be a delay getting the scan.
Treat first if delayed diagnosis. Makes sense. For patients with cancer and a new proximal DVT or PE, they recommend a review specifically at 6 months to reassess treatment. They reinforce giving VTE prophylaxis within 14 hours for at-risk hospitalized adults.
Prompt prophylaxis.
Prompt ultrasound for anyone with a Wells score of 2 or more. Regular review and monitoring for anyone on anticoagulants. Trying to achieve same-day assessment and management for likely DVTs.
Aiming for speed.
Yes. Individualizing the anticoagulant choice. And they specifically suggest considering apixaban or rivaroxaban, 2 of the DOACs, as first-line options for confirmed proximal DVT. And again, mentioning IVC filters if anticoagulation is contraindicated.
Okay, useful pointers from NICE. Any other sort of additional management thoughts?
We mentioned avoiding below-knee graduated compression stockings for the acute DVT, IDC filters we've covered.
Sure.
There's also catheter-directed thrombolysis, basically, threading a catheter to the clot and delivering clot-busting drugs directly.
Thrombolysis, okay. Is that common?
It's not routine for most DVTs, but it might be considered in selected cases, particularly extensive iliofemoral DVT in younger patients, mainly to try and reduce the risk of severe post-thrombotic syndrome later. It carries higher bleeding risks, though.
Right, risk-benefit balance.
Absolutely, and always, always crucial. Try to identify and address any underlying cause for the DVT. Was it provoked? Is there an undiagnosed cancer? Thrombophilia. That really shapes the long-term plan.
Okay, that covers management pretty thoroughly. So after treatment, what's the outlook? What's the prognosis like for someone who's had a DVT?
Well, the unfortunate reality is that recurrence is quite common.
Recurrence, okay.
If someone has a PE and stops anticoagulation, their risk of another VTE within just 3 months could be as high as 50%. That's why treatment duration is so important.
Wow, 50%.
Yeah. But with a standard 3-month course of anticoagulation after a first VTE, the risk of recurrence in the following year is much lower, maybe around 8%. Still significant, but much better.
So treatment makes a huge difference.
Massive difference. And interestingly, wearing compression stockings long-term after the acute phase does seem to help reduce recurrence risk, as well as managing post-thrombotic symptoms.
Right, stockings for prevention later on.
PE is obviously the most serious immediate complication we worry about. The risk is higher if the clot is more proximal, higher up the leg, like in the iliofemoral veins. And that iliofemoral location is also strongly linked to developing post-thrombotic syndrome.
Okay, you mentioned post-thrombotic syndrome a couple of times. Can you tell us a bit more about that? What exactly is it?
Sure. Post-thrombotic syndrome, or PTS, is a chronic complication. It happens because the DVT damages the veins, and especially the valves, inside the veins in the affected leg.
Damage to the valves?
Yeah, these valves normally stop blood flowing backwards. When they're damaged, you get persistent high pressure in the veins, chronic venous hypertension.
And what does that cause symptom-wise?
It leads to things like chronic leg pain, persistent swelling, skin changes like hyperpigmentation, darkening of the skin, and in the worst cases, it can lead to venous ulcers, which are really difficult to heal.
Sounds quite debilitating. How common is PTS?
It's estimated to affect quite a significant number, somewhere between 20 and 40% of people after a lower limb DVT develop some degree of PTS.
Up to 40%. Are there factors that make it more likely?
Yes, certain things increase the risk. Older age when you have the DVT, being obese, having had a DVT before in the same leg, if the clot was high up in the iliofemoral vein, and maybe if the anticoagulation wasn't managed optimally in the initial phase.
Okay. Is there anything that can be done for PTS?
Management is mainly supportive. Compression stockings are key here. But for some severe cases, particularly with iliofemoral obstruction, procedures like percutaneous stenting to open up the vein have shown some promise.
Stenting, interesting.
And on a brighter note, if the initial DVT was asymptomatic, the risk of developing PTS seems to be quite low.
That's something, at least. So just to quickly recap the main complications of DVT then.
The big two really are pulmonary embolism, the clot traveling to the lungs, the acute danger,
Right.
and post-thrombotic syndrome, the chronic leg problems that can develop afterwards.
PE and PTS.
Got it. Well, that has been a really comprehensive run-through of deep venous thrombosis. We've covered a lot of ground.
We certainly have. From the definition, Virchow's Triad, all those risk factors.
Yeah, the differentials, how common it is, how it presents or often doesn't present.
Diagnosis with ultrasound and D-dimer, the anticoagulant management strategies, prognosis.
And those key complications. It really highlights how important it is to, recognize the risks, spot the signs, and get treatment sorted promptly.
Absolutely. And maybe if you take away just a few things. Remember Virchow's Triad for the causes and risks. Think Doppler ultrasound for diagnosis. And anticoagulation as the treatment mainstay. Excellent summary points. And for you listening, especially if you're revising, try linking those risk factors back to the Triad: hypercoagulability, stasis, endothelial injury. It's a great framework. Remember ultrasound first for diagnosis, anticoagulation for treatment, and be aware of PE and PTS.
And if you want to test yourself or dive deeper, definitely check out passthemsra.com.
And freemsra.com as well, both great resources for practice questions and more.
Definitely worth a look.
Okay, perhaps a final thought to leave you with. Maybe consider the evolving landscape of anticoagulation, the shift towards DOACs, but also the ongoing challenges, particularly in complex patients or when long-term treatment is needed, or perhaps the difficulty in tackling those silent, asymptomatic DVTs before they cause problems, something to mull over.
Good points to ponder.
All right, well, thanks for joining us for this deep dive into DVT. We really hope this focus session gives you a clear, high-yield overview for your revision and your practice. Keep up the great work.
Yes, all the best.